It is a Tuesday afternoon in August. The air in South Carolina sits at 97 degrees, heavy and wet, the kind of heat that makes the surface of everything shimmer. She is 28 years old. 3 weeks from now, she will submit the final chapter of her graduate thesis. Today, she is at the lake with friends, and the water looks cold from the bank, and she is already running toward it. She dives under. For 1 second, maybe 2, water forces itself up into her nasal passage. She surfaces, shakes her head, wipes her face. Her friend says something and she laughs. She floats on her back and stares at the sky. The afternoon moves on. Freeze on that moment. That single second of water in her nose. Of 167 documented cases of this infection in the United States since 1962, 4 people have survived. 4. The kill rate is 97%. And in the next 5 days, that statistic will stop being a number and become the entire shape of her life. She doesn't know what is already happening inside her. In a moment, you will. 2 questions are going to pull through everything that follows. First, what exactly happens inside the human body after that 1 second of water? And second, if 167 people have died from this infection across 62 years of documented cases, why does almost no one know it exists? The lake she swam in was 84 degrees Fahrenheit that afternoon. That detail matters more than almost anything else in this story. Naegleria fowleri is not a parasite. It is not a bacterium. It is a free-living amoeba, a single-celled organism that has existed in warm, freshwater sediment for millions of years, long before humans arrived to swim in it. It does not hunt people. It does not want to infect anyone. Humans are, from an evolutionary standpoint, a dead end for it. Under normal conditions, it feeds on bacteria in lake sediment, reproduces, and goes entirely unnoticed. But Naegleria fowleri is thermophilic. It thrives in heat. The CDC's surveillance data identifies 80 degrees Fahrenheit as the threshold. Above that temperature, the amoeba becomes active, moves toward the surface, and concentrates in warm shallows. The lake she swam in was 84 degrees that afternoon. The amoeba was not lurking. It was simply there, doing what it has always done, in water that had become warm enough to sustain it. When she dove under and water entered her nasal passage, the amoeba encountered the olfactory epithelium, the sensory tissue lining the upper nasal cavity. Under normal circumstances, this tissue detects scent molecules. For Naegleria fowleri, it is something else entirely, a binding site. The amoeba attaches. What happens next is the reason the kill rate is 97%. And it has nothing to do with the amoeba's lethality and everything to do with anatomy. From the olfactory epithelium, the olfactory nerve fibers run upward through the cribriform plate, a paper-thin section of skull at the base of the brain, riddled with small holes through which those nerve fibers pass. It exists to let your sense of smell function. It is also, in the precise worst way, an open door. The amoeba travels up the olfactory nerve, passes through the cribriform plate, and enters the brain. It has bypassed every immune checkpoint the body has. There is no blood-brain barrier protection at this entry point. The immune system does not see it coming until it is already inside. The lake was 84 degrees. The cribriform plate is a millimeter thick. The distance between those 2 facts is 5 days. Primary amoebic meningoencephalitis. PAM. That is the clinical name for what happens next. And the name is almost gentle compared to the reality. The amoeba does not simply colonize brain tissue the way a bacterial infection colonizes. It secretes enzymes that dissolve neural cells, then consumes the dissolved tissue as fuel. It moves through the brain the way a fire moves through a house, not with intent, but with appetite. No strategy, just chemistry and warmth, and an endless supply of what it needs. It targets the olfactory bulbs first, then the frontal lobes, then deeper structures. As tissue is destroyed, the immune system finally registers the invasion and responds, but the inflammatory response itself becomes part of the damage. The brain swells. Inside the rigid skull, there is nowhere for swelling to go. The pressure builds, the swelling accelerates the destruction. The destruction drives more inflammation. It is a closed loop with one exit. Here is the timeline that governs everything that follows. Day 1 after infection, nothing, no symptoms. The amoeba is establishing itself. Day 2, Headache, severe, unusual, not responsive to standard pain relief. Day 3, stiff neck, nausea, sensitivity to light. Day 4, neurological symptoms. Confusion, disorientation. Personality changes, seizures. By day 5, most patients are dead. Average time from first symptom to death, 5 days. The speed is the kill rate. Not because there is no treatment. There is one. But because by the time anyone understands what they are treating, the window has already closed. The brain does not wait for the diagnosis. Day 2. She wakes up with a headache that sits behind her eyes and does not move. It is August. She has been outside in 97-degree heat. She has not slept enough. She takes ibuprofen. It does not touch the pain. She drinks water, lies down in a dark room, waits. The headache does not change. This is explainable. Heat, dehydration, stress, the thesis deadline 3 weeks away. She goes to sleep. Day 3. She calls her mother in the morning. Her neck is stiff, not sore the way a muscle aches, but resistant, like something is pulling against movement. She has nausea that comes in waves. Her mother asks if she has a fever. She does not know. She Googles her symptoms. Headache, stiff neck, nausea, light sensitivity. The first result is meningitis. She reads the page. She is not wrong. Meningitis is exactly what she has, in the clinical sense that her meninges, the membranes surrounding her brain, are inflamed. But the word meningitis covers dozens of causes: bacterial, viral, fungal, autoimmune. She has the rarest and most lethal cause that exists. She does not know that. She waits to see if it improves. It does not improve. Day 4. She wakes up and walks to the kitchen. Her roommate's photograph is on the refrigerator, a picture from a trip they took together 6 months ago. She looks at it. She knows, in some abstract way, that she should recognize the face in the photograph. She cannot make the connection. The face is a face. It belongs to no one she knows. She stands in the kitchen for a long moment, holding this wrong feeling, and then her roommate walks in from the bedroom, and she does not recognize her either. This is prosopagnosia, the inability to recognize familiar faces. It is not confusion. It is not forgetting. It is the specific failure of a specific neural process, and it means the frontal lobe is compromised. The amoeba has been consuming tissue for 72 hours. Her roommate looks at her face and calls for help. This is what happens inside the body after that 1 second of water. Now you know. The emergency room. The attending physician orders a lumbar puncture, a spinal tap. A needle is inserted between the lumbar vertebrae to draw cerebrospinal fluid, the liquid that surrounds and cushions the brain and spinal cord. Normal CSF is clear, like water. Hers is cloudy. Under the microscope, the technician sees them. Trophozoites. The active feeding form of Naegleria fowleri. Moving. Still consuming. The ER physician has almost certainly never seen this. Most physicians never will. 167 confirmed cases across the entire United States in 62 years means the average American physician will practice an entire career without encountering PAM once. The CDC receives a call. The diagnosis is confirmed. There is one treatment protocol. Miltefosine, an anti-cancer drug that was later found to have activity against certain amoebic infections, combined with amphotericin B, an antifungal agent that can cross into brain tissue. This combination has saved 4 people in the entire documented history of PAM in the United States. 4. The drugs are administered immediately, and now the only question that matters is whether the medication can stop the amoeba faster than the amoeba can consume what remains. With PAM, the answer is almost always the same. Those 4 survivors are worth examining carefully, because what they share is not luck, it is timing. Kaylee Hardig, 12 years old. Arkansas, 2013. She is the first U.S. survivor in decades, and her case changed the treatment guidelines. She was diagnosed within the first 48 hours of symptoms, before neurological collapse. Arkansas Children's Hospital used an experimental protocol: miltefosine, amphotericin B, and therapeutic hypothermia. deliberately cooling the body to slow brain metabolism and reduce the inflammatory swelling that kills as surely as the amoeba itself. She survived. She has neurological effects she will carry for the rest of her life, but she survived. The other 3 survivors share the same critical variable: early diagnosis. Within 24 to 48 hours of the first symptom, before the frontal lobe is compromised, before prosopagnosia sets in, before the cascade becomes irreversible. Early diagnosis requires the treating physician to think of PAM, to hold it as a possibility when a patient presents with severe headache, stiff neck, and a recent history of freshwater swimming. PAM is so rare that most physicians never consider it. The differential diagnosis for those symptoms is long, and PAM sits near the bottom of every list. She arrived at the ER on day 4. The neurological collapse had already begun. The window for the outcome Callie Hardig had was not narrow. It was closed before she walked through the door. The drugs were given anyway. They were not enough. What the CDC's surveillance data shows, mapped across 6 decades, is a story that is still unfolding. From 1962 through the early 2000s, PAM cases were almost exclusively confined to Florida, Texas, and the Deep South, states where freshwater temperatures consistently exceeded 80 degrees Fahrenheit in summer. The geographic distribution was stable enough that Naegleria Fowleri was sometimes called a southern disease. Then the map begins to shift. 2010, a case confirmed in Minnesota. 2012, Indiana. Cases appearing in states where, 30 years earlier, freshwater temperatures rarely reach the threshold the amoeba requires. The mechanism is not complicated. Lake surface temperatures across the Midwest and Mid-Atlantic are now regularly exceeding 80 degrees in July and August. Temperatures that were anomalous in those regions 3 decades ago and are now seasonal baselines. The amoeba did not migrate. It did not travel north in some carrier. It was already there, dormant in sediment, present but inactive, waiting for water warm enough to sustain it. The water caught up to where it was, waiting. The South Carolina lake was 84 degrees. A lake in Minnesota in August 2010 was 82 degrees. The number that separates a safe swim from a fatal one is 2 degrees of water temperature. That margin is shrinking in more places every year. What does the CDC mandate in response to this? At public freshwater swimming areas, no federal requirement for warning signs. There's no federal reporting trigger that would prompt public notification after a confirmed PAM case. The 167 documented cases are confirmed diagnoses, which means the true number is likely higher. PAM mimics bacterial meningitis closely enough that cases moving faster than the diagnostic workup can keep up, simply get recorded as meningitis of unknown cause and closed. State health departments vary enormously. Some issue seasonal freshwater advisories, most do not. The lake she swam in had no signs. The Minnesota lake had no signs. Prevention is simple. It is almost completely effective. A nose clip, the kind competitive swimmers use, the kind sold at any sporting goods store for less than $2, prevents water from entering the nasal passage. No nasal entry, no infection. The olfactory epithelium never encounters the amoeba. The cribriform plate is never reached. The entire chain is broken by a small piece of foam and wire that costs less than a cup of coffee. The lake is still there. Right now, in August, it sits at 84 degrees Fahrenheit. The surface catches the light the same way it did when she ran toward it. There are no warning signs on the bank. There are no federal requirements that there should be. Someone will swim there this summer, probably this weekend, and they will dive under, and water will enter their nasal passage, and they will surface and shake their head and wipe their face, and they will have no idea. That is the thing that doesn't leave you when you sit with this story long enough. 167 cases in 62 years is a small number. It is genuinely small until you are one of them. And then it is the only number that has ever existed. She was 28 years old, 3 weeks from finishing her graduate thesis. She dove under for 1 second, maybe 2, and she was already gone. She just didn't know it yet. Her body would take 5 more days to catch up to what had already been decided in that moment. The 97% kill rate is not a fact about biology. It is a fact about information. Nose clips, warm freshwater, summer. That is the entire intervention. $2, a piece of foam and wire. That is what she didn't know. That is what no one told her. The lake is still there. So is the amoeba. So is the gap.